Hi, my name is Dee Tennyson, and I hope you enjoy my review of literature PowerPoint. My preceptor and I were recently discussing current recommendation changes regarding self-breast exams and their effectiveness in detecting breast cancer, and our discussion really made me think why the recommendation changes. So recommendation for breast self-exam are changing and is being replaced with the idea of breast self-awareness. Research into the effectiveness of breast self-exam peaked in the early 2000s, and in 2009 the U.S. Preventative Task Force and the American Cancer Society issued new guidelines dropping their recommendations regarding breast self-exam in women, basically stating that it was no longer effective. I feel this is a good time for this PICO question because the status of women's breast health is ever-changing and really confusing at times. My PICO question is, in adult women, is self-breast exam as effective as clinical breast exam in early diagnosis of breast cancer? So for rating my research evidence, I used the Johns Hopkins model and guidelines, and you can see listed here is the strength of evidence levels 1, 2, 3, 4, and 5. This model also provides a quality of evidence: A, high quality; B, good quality; and C, low. For my search strategy, I used a variety of databases: CIN, AHL, Medline, Embase, Cochrane Library, and PubMed. I looked for keywords such as breast cancer, women age greater than or equal to 40, self-breast exam, clinical breast exam, early diagnosis guidelines, and breast awareness. So let's take a look at the literature. This first literature was titled Breast Cancer Screening for Women at Average Risk, 2015 Guideline Update from the American Cancer Society. This was a Level 2 high-quality study, and the purpose was to update the American Cancer Society breast cancer screening guidelines for women at average risk of breast cancer. The sample size was 18,842 to greater than 2 million women aged 30 to 79. The findings for this study showed that women at average risk of breast cancer should undergo regular mammography screening starting at age 45. CBE was not recommended for asymptomatic women at average risk, and SBE recommendations were not reviewed in this guideline. My next literature was titled Screening for Breast Cancer, Systematic Evidence Review, Update for the U.S. Preventative Services Task Force. This was a Level 2 high-quality study. The purpose was to determine the effectiveness of mammography screening in detecting breast cancer mortality among average-risk women, age 40 to 49 and 70 and older. It also reviewed the effectiveness of CBE and breast self-exam and harms of screening. The sample size is listed here on the PowerPoint, along with the dependent and independent variables. Instruments used. The findings of this study were that mammography screening does reduce breast cancer mortality for women aged 39 to 69, and the data was insufficient for older women. There was no benefit shown for CBE, although trials are still ongoing, and there was no benefit shown for women to perform self-breast exam, although it did state in the study that women performing self-breast exams had increased benign biopsies. The next literature was a Preventative Healthcare 2001 update. Should women be routinely taught breast self-exam to screen for breast cancer? This was a Level 2 good quality study. The purpose was to evaluate the evidence relating relating to the effectiveness of breast self-exam to screen for breast cancer and to provide recommendations for routine teaching of BSE to women in various age groups as part of the periodic health exam. So basically, should we be teaching women BSE? The sample size varied by study, but it looked at ages of women age 40 to 69. The findings showed that in women 40 to 49 years of age and 50 to 69, there was fair evidence of no benefit and good evidence of harm. It showed that there is fair evidence to recommend that routine teaching of breast self-exam be excluded from the periodic health examination of women in these age groups. The next literature was a breast self-examination and death from breast cancer, and this was a meta-analysis, Level 3 Good Quality Study. The purpose of the study was to prove that self-breast exam is not an effective method of reducing breast cancer mortality. The instrument for this study was Medline, Embase, and CancerLit databases. The findings showed that SBE is an unlikely alternative for breast cancer detection, even as a screening tool. Women should practice self-breast awareness and report concerns to their primary care provider. SBE is not more effective at reducing breast cancer mortality than finding a tumor just by chance. The next article is titled Breast Cancer Screening Controversies. This was a Level 3 Good Quality Study. The purpose was to provide the controversy. The purpose was to review the controversy regarding breast cancer screening. The sample size varied by study, and it included women aged 49 to 74. The findings showed that what should we be advising women about mammography? That it is still effective and a beneficial tool for breast cancer screening. Should physicians instruct women patients to do breast self-exam? And the study showed no convincing evidence that breast self-exam increased detection rates or decreased mortality. But it did state that if women were adamant about doing self-breast exam at home, that we make sure and teach them the proper techniques of how to do it. The next question that this article brought to light was, should physicians perform clinical breast examinations? And it found that CBEs do increase case findings of breast cancer, but it's unknown if this improves the patient's outcomes. It did state that improved techniques and sufficient time for the CBE to be performed is important. The next article was Performance and Reporting of Clinical Breast Examination, a Review of Literature, Level 4 Good Quality Study. This was an article that I found in PubMed, and its purpose was a literature review providing evidence to support the specific recommendations for optimizing CBE performance and reporting, to guide further research on CBE performance characteristics, reporting systems, barriers to high quality CBE performance, and training. The findings found that CBE identifies some breast cancers not found by mammography, which I found pretty interesting. CBE recommended for women under 40 or 50 who it is not recommended that they have a mammogram, so it was beneficial for them, for that age group. And it was also helpful for those that don't have access to mammography or that just plain out down refuse to get a mammogram. And one thing that this study brought to light, or this literature review brought to light, was that healthcare professionals need to recognize the additional training for CBE performance techniques. We need to make sure we're doing it right. And the next study was titled Breast Self-Examination. It was a level 4 good quality study. The purpose was to examine the value of teaching regular breast self-examination. You can see my independent sample size. The findings found that breast self-examination should not be routinely taught to women. A full discussion of breast self-examination, including the risks, should be provided to the women who request it, and if a woman wants to make an informed decision to practice breast self-awareness, we need to make sure that she's taught the proper skills to do so. So what does this all mean? What I took from it was that self-breast exam is really no benefit to the patient. There's fair evidence to actually exclude self-breast exam from our clinical practice, and there's just no convincing data of effectiveness in decrease that self-breast exam decreases breast cancer mortality. And that it should not routinely be taught to women unless they are adamant about performing it, and if they are, we need to make sure we're teaching them the proper way to do it, to perform self-breast exam. CBE is not recommended for women of average risk and asymptomatic. Actually, some of the literature review showed that CBE had no benefit, but then it was also recommended that women under 40 to 50 who are not under the recommendation guidelines to get a mammogram, that they should have CBE, and CBE was found effective for women that didn't have a means to get a mammography, or that they refused to get a mammography. And of course, as we know, mammography is an effective and beneficial tool for breast cancer screening. Implications. So let's look at implications to practice. And for one, let's go back to the PICO question. And I feel that based on the literature review, that SBE is not as effective as CBE in early diagnosis of breast cancer. It got me thinking, what have I observed in my clinical rotations? What I have seen is that the practitioners I've worked with are not asking patients if they're doing self-breast exam. If the patient is adamant about doing self-breast exam, they are teaching them how to do it. But they really are teaching women to be more aware of their breasts and to report any concerns such as pain, nipple drainage, or any lumps that are found. In the clinicals that I've been in, clinical breast exams are being done on all women during complete physical exams, and mammograms as per current guidelines. So putting this all together kind of got me thinking about, I'm going to be graduating soon. How am I going to practice? I want to teach my patients about self-breast awareness and when to report concerns. I plan on doing complete breast examinations on all women during my complete physical exams, or if they present with breast concerns. And definitely want to strive to improve my clinical breast examination techniques. And if women are adamant about doing self-breast exam at home, I will do my very best to teach them the proper way to do it, the proper skills. And then I will continue to order mammograms as appropriate based on my clinical breast examination, family history, and recommendation guidelines. And here is my list of references. Thank you for viewing my PowerPoint. I hope you found it helpful in moving forward with your clinical practice.